A warm good morning, everyone. I think we'll start the session. Welcome to our symposium on why Lenticule. As you all know, refractive surgery is evolving rapidly, very rapidly, and from the days of surface ablation, we have come to the days of lenticule extraction. Today, I'm very happy that we have eminent speakers from various institutions all over the India, and we have very good topics to cover on lenticule extraction. And I hope all of you will enjoy and benefit from this session. We have speakers, Dr. Pooja Kama from Bangalore, Dr. Sanjeev from Chennai, Dr. Rohit from Cochin, and Dr. Rushad. Unfortunately, he cannot make it today due to some personal problems. And Dr. Chitra Ramamurthy will be giving the keynote address. So I think we'll start with my topic, overview on lenticule procedures. I think the speakers can come to the dais so that we can have discussion. Please, all of Dr. Pooja, Dr. Rohit, and Dr. Sanjeev. Good morning once again. In the next few minutes, I'll be giving an overview of the lenticule procedures. Okay. So, as I said, the refractive surgery has evolved rapidly. The lenticule procedures have evolved in a span of a decade. It has come to the mainstream of refractive surgery procedures. So, let me talk about the journey of refractive surgery. We started with PRK. PRK, it was a bladeless, flapless procedure. Then we moved on to blade LASIK with blade, mechanical microkeratome. Then we got femtosecond LASIK. With this, we used to make a flap. Then to move on to complete the circle, we are back to bladeless, flapless, lenticule-based procedures, which is termed under CLEX. What is CLEX? CLEX, it's a keratolenticule refractive lenticule extraction procedures. It is termed under CLEX in the year 2023. All these procedures started with the introduction of femtosecond laser. Professor Sekanto and Blum introduced flex with femtosecond laser. They made the flap and the lenticule. Later improvised to small incision lenticule extraction procedure in the year 2007. It is recognized as the birth of SMILE, and Dr. Rupal Shah performed the first SMILE procedure in India. This is the geometry of a lenticule. It is a minimally invasive procedure. We use the femtosecond laser to create the lenticule according to the refractive error of the patient, and the lenticule is manually separated and it is extracted through an incision of 2 to 4 millimeter. We have various platforms available all over available from various companies. The Elita Silk, then comes the SMILE, Visomax has 500, and now the latest Visomax 800 is we can do Smile Pro with that. Then Clear from Zima and Smart Sight from Schwint. Let us go through the various parameters of each machine. Overall, the energy wavelength is almost same as around 1040, but the main difference is in the laser pulse repetition rate, which is the laser pulse repetition rate is maximum with the Zima, and then comes Elita. And all this while we were trying to reduce the amount of energy per pulse from the earlier days. So we have come up to 50 to 70 nanojoules with Zima. And next is with the Atos. Then different patient interface platforms are available. It is curved with Visomax 500, 800 as well as Atos, and it is flat with Zimmer and Elita. And the major problems in the initial days of lenticule extractions were the cyclotorsion compensation and the centration issues. Now we have rectified that. Other than the Visomax 500, we have impulse cyclotorsion compensation and post-docking centration system in all the machines. And there is a lenticule side cut with Visomax 500, 800 as well as Elita. It is not there with Atos and Zima. And the shape of the lenticule is planar convex in all the machines except Elita. It is biconvex lenticule. The main advantages of lenticule procedures, other than the other techniques like PRK, LASIK, there is no flap, so we are not cutting the corneal nerves, only the 2 to 3 millimeter incision on the superior part. Very few nerves are transected, so less induced dryness, and no flap, so there is no flap related complications as well. And we are not disturbing the anterior stroma as well as the Bowman's membrane in lenticule procedure, so better preservation of corneal biomechanical strength and less induced dryness, less induced IOP rise intraoperatively, and less higher order aberrations, induced aberrations. And the environmental factors like humidity, temperature are not affected with lenticule creation like with excimer laser ablation. There are certain limitations too. The learning curve is a little longer because we have to identify the lenticule, separate the lenticule. We do it manually. It takes a little more time compared to the other procedures. And initial days we can have incomplete lenticule extraction. And the hyperopic correction is, as of now, it is not possible, but it is almost on the way. We may get it in few months or by next year. And pure astigmatism also is not possible. And the cost, especially the initial investment and the consumables, are little on the higher side. What are the major changes since 2007? The lasers have become more faster and the incision has become smaller, and we got dedicated instruments. We have learned more about the instruments, and the cyclotorsion compensation and the post-docking compensation is improved, and the energy management, that is the most important. We got better idea about how to optimize the energy. That is very important for the results, post-operative results and intraoperative lenticule management. And retreatment options are available now with Visomax. Circle software is available, and the hyperopic treatment we can expect within few months. And now the lenticule, whatever is lenticule implantation procedures are done for keratoconus and sometimes for hyperopic treatment also. Let me share a few of my learning experience. I started with Silk. We have the Elita machine. Dr. Rushad was kind enough to be there during my early days of surgery. And energy optimization is the key for postoperative visual recovery, fast visual recovery, and the instrument, as and when the numbers increases, we can modify our instruments according to our convenience and the procedure. To conclude, lenticule extraction has matured to a highly predictable, minimally invasive, a flapless refractive surgery option. It is no longer a future, it is the present of refractive surgery, and it is going to stay here. Thank you. Now, let me, ma'am is doing the keynote now. You want to do it later? So, may I call Dr. Rohit Georgie Matthew to talk on clinical outcomes in smile surgery. Dr. Rohit is a consultant cataract and cornea services at Lotus Eye Hospital, Kochi.
Good morning, all. Thank you, Dr. Kala, for the invitation. So I'll start. No financial interest on any companies. So it's basically it's a minimally invasive laser vision correction reformed as keratolendicular extraction. These are new machines. Already Dr. Kala has explained regarding this. So I'll be talking about Visumax 500 and 800. So it's from Carl Zeiss, and the laser specification, just the minimal details. The laser wavelength is around 1043 nanometers, and the pulse duration frequency is around 5000 kilohertz for the 500 and 2 megahertz for the 800. So the energy per pulse rate is 110 nanojoules to 150 nanojoules, and the laser spot size is 0.5 microns to 1 micron diameter. And it's a 3D placed distance of around 2 to 5 microns, and it's a spiral shaped delivery. So the mechanism is basically the ultra short lasers powered high power pulses at a very high speed, and bonds between cells broken by photo disruption, resulting in micro gas bubble creation, creates tissue cleavage, resulting in a precise tissue transaction at the focus plane within the cornea. So these are normal dimensions we used to keep. Depending upon the pupil size, the optic zones can be customized, and the flap diameters is 0.5 to 1 mm oversized to the optic zone, and the cap thickness is ranges from 100 to 120 microns, and the side cut is 2 to 5 mm placement at 90 and 180 depending upon the surgeon's convenience, and the refractive correction determines the size and shape of the lenticule. So this is the cross section, lenticule, vertical cut, cap cut, and the last side cut. So the main benefits are, it's a convex shaped lenticule. The subbasal nerve plexus relatively spared, and the subepithelial plexus are also spared. So dryness is comparatively lesser than LASIK, and the stromal innervation dents at the periphery are not affected. So corneal sensation is better, and the iatrogenic dry eye is less. So these are the clinical data which I have. I've been doing SMILE for the past 8 years, and the visual acuity, accuracy, contrast sensitivity, corneal strength, stability, dry eye, and safety. So this is a article which is published in the JCRS, where there is a visual outcome of SMILE versus LASIK, and the 96% of the patient achieved 6 by 6 or 20 by 20 vision within in a span of 3 months, and whereas in LASIK it is 92%. So in conclusion, the 3 months result demonstrate the refractive accuracy, dry eye, contrast sensitivity, and the induced aberrations are better following SMILE rather than LASIK. So in the higher order aberrations, the conclusions are the induction of the higher order aberration after femtolasic and relaxed smile was small and similar when compared to two techniques. In a study comparing smile with the LASIK, the higher order aberration and spherical aberration were significantly lower in smile cohort. And in contrast sensitivity, neither mesopic nor photopic contrast sensitivity show any significant changes. So in conclusion, relaxed smile produced satisfactory refractive outcome with unaffected contrast sensitivity after 1 year. and the corneal hysteresis and the corneal resistant factors. In conclusion, the flap-based LASIK and the Relax Smile, Clex and the Relax Smile results in the similar reduction in corneal biomechanics when evaluated with Corvus and ocular response analysis. So, however, the mathematical modulation suggests that stromal tense strength should be stronger with smile compared to LASIK, is because the anterior corneal stroma is not affected. So in case of regression, the considering long-term predictability and the stability, 89% of the eyes were within the 0.5 diopters and 100% were within 1 diopters of intense refractive target in a duration of 5 years. So in conclusion, the long-term data also suggests that the smile has a excellent stability. So in case of dryness also, the reduction in subbasal nerve plexus and the nerve density are significantly less in smile treated eyes than femtolaser LASIK treated eyes. This is a span of 1 week, 1 month and 3 months respectively. So this also defines that comparatively dry eye is less in smile than LASIK. So this is a confocal microscopic image of smile versus LASIK in a 1 week, 2 week and a 4 week scenario. The upper one is a smile and the lower is a LASIK, where you can see the subbasal nerve plexus are preserved. And in safety, the demonstrated after 1 year, smile is as effective, predictable and safe, minimally invasive corneal refractive procedure. So in astigmatism also, in certain condition, if you have a cyclotorsion machine like the 800, the absolute angle of error was significantly lower for smile compared to PRK. Possible reason for this is better centration in the smile that is maintained via continuous suction. In comparison, analysis with smile and LASIK report that decentration in smile in which was affected the overall alignment of the astigmatism treated. And these are the contraindications for CLEX. Corneal scars, family history of keratoconus, eye rubbing, corneal ectatic disorder, as same as the refractive analysis. And in pachymetry less than 480 microns and RST less than 260 microns, you can consider doing a smile extra procedure. So in what you do is smile extra is it's a simultaneous cross-linking has been proposed as an adjunctive therapy to corneal refractive procedure to prevent future ectasia, especially when performed in a borderline corneas. So risk factors such as thin cornea, abnormal topography, history of eye rubbing and a family history of any keratoconus or pregnancy or hormonal imbalance, you can consider doing smile extra. So what is done? So a normal smile is done followed by 0.23% of riboflavin in saline injected into the interface and allowed to diffuse for 60 seconds, which is then rinsed with balanced salt solution, and a UVA radiation is performed through the cap using a 45 millivolt per centimeter square for 75 seconds, delivering a total energy of 3.5 joules per second centimeter square. So in conclusion, higher power correction, anterior stroma is not affected, and less higher order aberrations, less higher order aberration, and biomechanics are less affected post smile, and simultaneous cross-linking in borderline cornea, and the iatrogenic dry eye is comparatively less, and the wow factor like the post-op day till day 1 itself patient attains a 6/6 vision. So this is just a video. So this is done in Visumax 500. The visual axis is aligned in the center, followed by the femtosecond lasers are starting with the posterior cut, followed by the anterior cut, the vertical cut and the side cut, and the patient is brought to the Zeiss microscope, and the side cut is identified, and the dissection is executed from posterior and anterior and posterior, followed by the lenticular extraction. Thank you.
Next, may I invite Dr. Sanjeev Srinivas to talk on Clear, a new reason to smile. Dr. Sanjeev is a consultant in cornea, cataract and refractive services at Chaitanya Eye Hospital, Trivandrum, and Darshan Eye Care, Chennai. Thank you. Over to Dr. Sanjeev.
So good morning. So seeing as CLEX seems to be the new way to go in refractive surgery, I thought I'll talk more about the procedure in itself. So we have at our place the Zima. So it's a mobile surgeon controlled unit. It's got a very easy to use patient interface and it offers very reasonable post-operative outcomes. So Zima call it corneal lenticule extraction for advanced refractive correction. We call it CLEAR. Now, the procedure itself is quite simple. It's very close to the other CLEX procedures. So what the company recommends is that you mark the axis 90 and 180 like you would for a toric. You can also use the Avad marker, which is available commercially. We prefer this because we haven't got the marker yet. Then the handpiece. Now, it's a handheld handpiece, unlike the gantry operated ones that you have in the Smile and in the Etos or in the Elita. So it allows you to either single dock or double dock. The double dock is a very easy option because it allows you to put the vacuum ring on top of the eye without too much patient movement, and it's very helpful in deep set eyes as well. You can also single dock. You can just hold the handpiece directly over the patient if you have a patient who's very cooperative. Both work equally well. Once the handpiece is docked, the machine then starts to apply vacuum. That takes around 5 to 7 seconds. You'll see that once the vacuum has been applied, the pupil tracker will engage. You'll see the ring around the pupil. And once that's done, the OCT will start. The OCT, you can then adjust the depth of resection wherever you want it to be. And then once that's sorted, you can even check to make sure your incisions are right, and then you can start resecting. So the resection is the same. The posterior cap goes first, the anterior cap is second, then you have the incisions, and then you have the venting tunnel. This entire process takes around 13 to 16 seconds on average, depending upon the power that you're correcting. The incisions are customizable. You can make one, you can make two, you can even make the incisions one into the anterior cap and one into the posterior cap, but all this is done in the planning stage. Now, when you're starting to dissect, it's a little different than what you do with Smile. You first have to find your planes. So basically, we use the spoke, which is a very small instrument. We pass it into the cap. This is the anterior cap. You'll find that it has more resistance. And then you'll pass it into the posterior cap. It's a lot smoother. You try to overlap these two grooves. And then if there's no resistance, it means you're there in the same plane. You're just dissecting the same plane over and over again. If there is resistance, it means that you found the anterior and the posterior planes. The next step is the dissection. Now, this being a biconvex lenticule, it doesn't matter. You can dissect either the anterior or the posterior cap first. The anterior cap takes a little longer because the stroma is a lot stickier. As you can notice here, the dissection is a little harder than the posterior cap. Once you finish the anterior dissection, you needn't have to actually cut the side walls. You just have to be sure to dissect the central part. You then move into the posterior cap where you see the dissection is a lot smoother and a lot faster. As you're finishing about 50 to 60% of the dissection, you will notice the lenticule start to fold over on itself. You'll see that bulge on the corner. That means that the lenticule has now separated. So then you move on to the extraction. So it's preferable to ask the patient to look down a little. This makes it a little easier. You then use the forceps to gently peel the lenticule out. Now the next step that we do here is the most important part. We check to make sure the lenticule has come out in its entirety. So you put a little drop of saline and you can use the forceps to gently smoothen it out. Make sure it's completely round and that you have no remnants left behind. The proprietary algorithm in the Zima makes sure that it's very hard for you to have a remnant lenticule left behind. Now, this is a bit of a controversial step, the pocket irrigation. Some people do it, some people choose not to do it. We do it. We put in a little aliquot of saline and then we gently brush and, brush the stroma from side to side, and then we use a Weck cell to smoothen it out and dry up the incision. Now, there are some people who say that overhydrating the pocket can cause stromal hydration and delays visual recovery on postoperative day 1. But then I have colleagues in the Middle East who actually put in dexamethasone or diluted triamcinolone to reduce the interface inflammation. So then again, this is a bit controversial, to each their own. Now, it's not you do have problems. The most common problems that we have with Clear is that you have smaller incisions. So if you have a patient who's moving around too much, or if you have a patient who's constantly uprolling, you'll notice that the incision is being torqued by the instrument, and what will happen when you finish your dissection is that you will be left with an incisional tear. This does heal, but it does cause significant postoperative discomfort. This is a black spot. This is where the laser has not cut the cap. You see the area there where there's no bubble, no cavitation bubbles. So what will happen is when you try to dissect that part of the lenticule, you will have a bit of struggle because the lenticule has not been dissected completely. Because it's biconvex, you can dissect posterior and then come back up and dissect this part again. It'll just take a little while, and the patient will have a little bit of postoperative inflammation that will delay his or her recovery. You can have an adherent lenticule, especially in the periphery, so you may have to be gentle. So it's like tearing the check leaf out of a checkbook. You'll have to go and tear it off little by little from the periphery, and you can get it out in one go. Again, check to make sure that you've removed the lenticule in its entirety and that you've not left any remnants behind. Lastly, like I discussed earlier, the stromal hydration. If you hydrate, you'll notice the corneal stroma becoming hazy, and this will actually carry forward onto postoperative day 1. So yeah, just hydrate gently. Apart from this, the most common problem that we have in clear or any form of CLEX is the postoperative day 1 subconjunctival hemorrhage that you'll have to sit and explain to your patients. You can have uncommon problems as well. These are not seen very rarely. In fact, I've not had most of them. Intraoperatively, you can have an opaque bubble layer. You can have a cap tear. You can have an incisional tear like I showed you earlier. You can even have a cap perforation where your instrument can poke through from anterior and go posterior, or vice versa. You can have traumatic epithelial defects which cause significant problems postoperatively, and you can have a decentered ablation. However, that can be controlled using the cyclotorsion and the pupil centration correction. Postoperatively, we rarely see it, but you can have lamellar keratitis. We have had few cases of pressure-induced stromal keratitis, which were treated with reducing the steroids and adding anti-glaucoma medications. Residual errors, recurrent corneal erosions, interface infections. Higher order aberrations are very, very common. Patients do have glare and halos, especially in the first 1 month. We actually counsel them for it. Night driving sometimes becomes an issue, especially when you're correcting astigmatic errors. Ectasia regression, of course, has been described. Now, the disadvantages are pretty much the same as with any other CLEX procedure. You have limited power correction, especially when it comes to higher astigmatism and hyperopia. Like I mentioned earlier, the higher order aberrations, glare and halos do exist. You do have to tell the patient because it will delay his or her recovery time. And there is a little problem with neuroadaptation bilaterally, especially for patients who undergo any form of keratorefractive lenticule exchange procedure. But the clear is a surgeon controlled mobile unit. It offers cyclotorsion and pupil centration, manual of course, unlike the Smile Pro which is automated. It's mobile, and therefore it really helps when you're trying to reduce your cost per unit in terms of operations. And with that, I'll conclude. Thank you so much for your patient listening.
May I invite Dr. Chitra Ramamurthy for her keynote address on challenging cases in refractive surgeries. Dr. Chitra needs no introduction. Everybody knows her. She is the medical director of Eye Foundation Group of Hospitals and consultant in cornea, refractive, cataract. Over to you, ma'am.
A very good morning to our chairperson for this IC and all the friends in the dais, and thanks KSOS for this wonderful opportunity. So I'll go on to be talking on some of the challenging moments in CLEX surgery after the wonderful talks which we have heard this far. So now this is a very simple, straightforward refractive error 1.5 diopters, normal topography. Normally, when the lenticule is thin in smaller parts, you have the feasibility in smile surgeries to increase the lenticule thickness from 10 to 30 micron, so that makes you feel that the lenticule is thicker when you remove it instead of getting torn. This did not happen in this particular case. The optometrist forgot to increase the lenticule thickness. I wasn't aware of it. All the cuts were done absolutely properly and going quite good. So now that is done. So there's just a little bit of OBL. I create the anterior plane and the posterior plane. And once that is done, all you have to do is to just separate the lenticule from the overlying cap, and then you have to separate it from the underlying cap. Go right end to end. Don't leave any of these ends of the tissue bridges not uncut. And then I remove the lenticule. It comes like a cigarette roll, but I know when I spread it out that just 1/3 of the lenticule has come out. So there is still a lot of it inside, and also I know that the lenticule is too thin. So I have torn it in the process of removal. Then I removed the other part. So I can see the fold of the lenticule in the interface, and then I've spread it out, and I think it's done. Oh, the story is over. The next day, the patient comes with a -2 with 3.5 cylinder, and you can see the topography. So I know I still have a little bit of the lenticule in the interface. So now the next day, I have no OBL to guide me. So I just go inside, but what I do is inject 10% tricot. So now this is a big advantage. It doesn't stay in the vitreous alone, but it also delineates the lenticule. You can see the lenticule is horizontally placed overlying the pupil. Now it is stuck to the cap. So you need to insinuate your instrument to get one free edge, one edge. And once that edge you get, you hold on to it, and just like you're doing your X's, you move it circumferentially around and then spread it around. You realize so much of the lenticule is actually left behind. And then if you look at the post-op topography, post-op 6-9, and that's how forgiving the cornea is. And it's a message that you have to remove the lenticule and not leave the patient with an irregular astigmatism. And we even presented a paper about use of tricot in getting the retained lenticule identified. Now this was a patient who got SMILE done elsewhere 2 months back. He had just a simple 2.753 diopters. He had 6.6 in his left eye. The right eye was 6.36. Even when we did refraction, we got an irregular reflex. And if you look at the topography, it is steep on one side, it's become flat on the other side. If you look at the pachymetry, it's thicker on one side, thinner on the other side. So you know that nasally, it's thicker. So that means the lenticule is there somewhere in the nasal region. And even on a retro illumination in a well dilated pupil, you sort of get an outline of the lenticule which is there nasally. So now here in that time, I did not use tricot, which I would use now. So I decide that I have to work on the undersurface of the cap, which is where this lenticule is stuck. So I have to insinuate my instrument to get a space between the stuck lenticule to the overlying cap. And I have to work on the nasal region, which is where the lenticule is spread out. So with that much information, even if you get the reflection, if you look at the reflection, there is one area inferiorly where we know that the lenticule is actually getting folded. So then you go with your instrument, try to grip that folded area, and then just bring it round circumferentially, and you realize that this much of the lenticule is there. Post-operatively, if you look at the topography, it's all green. The patient has 6.6 and 6 parts. This was a patient who had a -8.5 with 2 cylinder in one eye and a -5 in the other eye. Nowadays, I would clearly not do LASIK even if it was the thickest cornea above -8. But this was done more than a decade back, and this patient had a normal topography prior to the procedure, very thick cornea. But 4 years later, she comes back with an inferior ectasia with my 2 and 4 cylinder. And you know what you have to do now is you have to regularize the topography. So the plan of action is to use one inferior intact segment which would reshape, because that much is enough. So basically you dock the patient and on the femtosecond laser create the channel and place a single segment so that it lifts up that flat steep area inferiorly and regularizes the topography. And the topography did get regular, and the refraction came down to -2.75 to 0.5 cylinder with the vision improving. The BCVA did improve. So then we waited for a period of 6 months till the refraction topography got stabilized, and then placed the phakic IOL, and the patient had a 6/9 vision. And we actually sent this lenticule to the NN and they found that the LOX levels were lower in this eye. So even if the topography was looking normal, biomechanical instability was what was the cause for the ectasia. Now this is a case, a very routine case. Patient was highly apprehensive. My last of my videos, the things are going good. But you know, I should have known and taken my foot pedal off, because once the incision before that the laser suction stops, the incision occurs in an aberrant area. So I'm not able to open up this lenticule. So what I do for the second eye, allow the posterior lenticule cut, the side cut, the cap bud, but I remove my foot pedal before the incision cut is made so that I can redock, because the patient was apprehensive. I redocked and again made a fresh incision. So now in the left eye, all I had to do was, all the cuts were done, and I've created an incision. So I go in a routine manner, define the anterior plane, the posterior plane, and I remove the lenticule. But in the left eye, before the incision cut, the laser had stopped. So I could not, that's the last step where you can't do. So what I do is, I use the circle software, make a large hinge, and leave that small area, which is for the flap cut, only that much area I leave it open. So now I have actually converted, it's actually a flap, but the hinge is all closed and just one small incision is left. And I go into the interface of this flap and the lenticule is lying there, and then I pull out this lenticule. So this was just that last minute strategy which came to my mind, how to deal with this moment, and the patient actually did well in both eyes. So last but not the least, I'm sure I've spoken to most of you all at different moments in my career. I'm contesting for the post of Vice President AIOS and would be really obliged if you keep me in mind. Thank you very much. Any questions?
Thank you, ma'am. Next, Dr. Rushad couldn't make it today, so Dr. Pooja will be covering the topics: silk route, improving outcomes with a new refractive procedure. And she'll be talking again on smart side, the clinical experience and wound healing perspectives. Dr. Pooja is from Bangalore. She is a surgeon and a translational researcher who works span refractive surgery, keratoconus management, ocular surface diseases. And she's presented various papers across the world. And over to you, Dr. Pooja.
Thank you, ma'am. Thank you, Dr. Kala, for inviting me here and giving me the opportunity to share our experience on lenticule procedures. So this is a topic my colleague and a senior Rushad was supposed to cover, but he couldn't make it because of family emergency, so I'll just be sharing my perspective. So we are all talking here about all the lenticule platforms, Smile, Clear, the silk, and then the smart side. So one thing always everybody keeps asking me, what is my favorite machine, or if I have to buy one, what would you choose? So just to begin with, comparison is the thief of joy. Always remember that whatever works the best in your hands is what you should probably go for. Whatever you feel the comfort with, a particular machine is one which you could go for, because we saw the presentation on Smile and then we saw it on Clear. Everything works good, but it has to be like what works good in your hands, what works good in your city, your patient profile. So you have to look at multiple aspects before you choose a machine, because every technology is good, every technology has its own uniqueness, but sometimes Clear may work good for my patients in my setup, my country, or my city, and maybe Smile may not work. So you just have to choose accordingly. So when it comes to silk, it does have a different lenticule profile. So now again, everybody is like, when the Smile was launched, it was a plano convex shaped lenticule, and it did have an edge over the preservation of nerves and a smaller side cut. But here it's a biconvex shaped lenticule with a side cut, and if you see the spot size, the energies and everything, the energies here are as low as 45 nanojoules. You can, based on your machine, you can go to 30 nanojoules also. But the second beautiful, most important part here is the spots are next to each other. The spots, if you can see, there's hardly any space. They're as small as 1 micron, and the spacing between the spots is also 1 micron. Compared to the conventional lasers, where the spot to spot distance can range anything from 2 to 4 to 7 microns. So here, that's the beauty of Elita silk laser. Because of that, it's technically a separated lenticule, so you don't need to like worry a lot on dissection, or you don't need to struggle a lot on dissection. How Dr. Sanjeev showed, to open the anterior posterior plane, you don't need to do any wiper movements. Just from left side to right side, one swipe on the anterior and posterior plane can help us to remove the lenticule, and that's how the 1 micron spot spacing and the 1 micron spots help. And because you're not doing too much of pressure on dissection of lenticule, the recovery in terms of the quality of vision is much faster compared to other platforms. And because of this, what you can do is it's like something like a rexis in your flax platform. You can just hold your lenticule and do something like a rexis, where you can do a circumferential tangential movement from 12 o'clock to 6 o'clock, and that's how you can remove the lenticule. So here also you just identify the anterior posterior planes, take your 23 gauge forceps, and just like how you do a rexis in your cataract procedure, you can do something like that and remove the lenticule. It works in 70 to 80% of the cases in beginner's hand, but again, always learn the traditional dissection and then go to this one of these techniques. And because whenever a peel procedure, like in a very small myop or something, it's not possible, dissection always is the thing which you could provide for. And now, because of with further optimization of the energies, you do not even need to do something like a rexis. You can just identify the planes, push the lenticule and pull it. So that's how this is the advantage of the spot spacing with the silk laser. And again, because you are minimally dissecting it, or there is no tissue bridges present here, there is a very smooth dissection, and that's how the quality of vision on day one is little better compared to that of other platforms. And this is some work we have done in terms of quality of vision, the retroillumination, the day one post-op, and the Bowman's membrane. So the second thing which I said is about the shape of the lenticule, and the shape of the lenticule is a biconvex. And because it's a biconvex shaped lenticule, probably it's preserving the peripheral nerves compared to that of smile as well, and that's when the recovery of nerves is little faster, and it also helps in many other ways. So this is how the two lenticule profiles look like: the plano-convex, which is the traditional, and the biconvex shaped lenticule in a real-time patient. And these are just the OCT images on how the lenticule shapes are intraoperatively for these patients. The quality of vision, 96% of the patients do achieve 20/20 uncorrected distance visual acuity at 1 week, and 4% do come back to 20/20 within a month. But the problem, the question here is, now do we just look at 20/20, the quantity of vision, or should we look at something more? Because every time we get a question, my LASIK patients are having a very good quality of vision, but my lenticule patients are not happy. So is it just the fault of a technique or something else? Probably the role, the shape of the lenticule could have a role in this. And we did some work on the aberrations, and these findings were supported by Rushad's work as well, where there was minimal change compared to whatever your pre-op aberrations were. There was minimal induction of higher order aberration post-operatively, especially the comas and the spherical aberration. And whenever you preserve the spherical aberration, you probably are preserving the depth of the focus for the patients, and that's how they have a good depth of focus for distance, intermediate, near, and this helps a lot for the pre-presbyopic patients as well. So we did, again, next thing, because it was preserving the spherical aberration, and we wanted to see whether it helps in the pre-presbyopic age groups. And this is a study which is done between the patients of 38 years to 45 years who are undergoing silk. And we could see that they could read as well. A lot of times when you operate a patient of 38, 39 or 40, they're not very happy post-operatively with the quality of vision. They say that, I have a lot more issues in focusing. So we compared the presbyopic healthy patients with the silk patients, and we could see that they are not losing that quality of vision or the depth of focus post-operatively in after silk procedure compared to that of what a healthy patient would look like. So because you're maintaining the spherical aberration, it's also maintaining your depth of focus, which is something like an EDOF kind of an effect, what you would see with EDOF lenses. And this was also supported by the curvatural changes, because of the shape of the lenticule, there was lesser change in SA and sphericity. And if you see the gradients from center to periphery, the gradient shift in a biconvex shaped lenticule was much lesser compared to that of a plano-convex lenticule. And also because the peripheral nerves are preserved, the regeneration is much faster here, and it also helps in epithelial remodeling much better in silk compared to that of a plano-convex shaped lenticule, which is the traditional laser. So this is just a beauty of the biconvex shaped lenticule, and this is some data of contralateral eye study of epithelium between plano-convex and biconvex, suggesting that the epithelial remodeling is much better or controlled here. So yes, silk does give us an advantage. It's a low energy laser. The spot sizing and distance is much more adequate because the spots are next to each other. It's technically a separated lenticule, so it's a very easy dissection, and it also helps in nerve regeneration also. So the quality of vision here is little better sometimes post-operatively. Thank you.
You can continue with your next talk.
So again, we'll switch now gears from silk to ethos, and have been fortunate to work on the smart site from ethos platform as well. So this talk is going to be also from what Schwind ethos is and how it helps in healing. As I said, every laser is different and every laser has its own uniqueness. The uniqueness of ethos is the, again, you can modulate the energies for the anterior and posterior plane, and I will come to it that how the spot spacing is different, and it's an asymmetric spot spacing for this laser. So the cumulative laser energy delivered here is much better, and because it's an asymmetric laser delivery pattern of the spots, again the dissections become much smoother here. The other so when it comes to Schwind, you have to manually cyclotorsion control and everything is there. But here, it's an intelligent eye tracking system where the cyclotorsion compensation is automated. If you link the Schwind ethos with a Cirrus or MS39 or Pyramis, you don't need to do a manual cyclotorsion. It automatically takes the cyclotorsion compensation into control. And because it takes the cyclotorsion into compensation into control, your cylindrical corrections are much precise here. Now they have introduced the Smart Sight Nova, and because of the Smart Sight Nova, it also takes care of the centration. The issue in the past we used to get with ethos is that the centration, we had to be very vigilant and probably try once or twice in uncooperative patient to have the exact visual centration. But here again, with the Smart Sight Nova, we have an accurate centering, which again helps in higher astigmatism correction. Now, the tissue geometry here is such, and if you compare between the different platforms, the tissue ablation for every diopter is much lesser here, and that is because of the optimized lenticule geometry. It doesn't have a side cut, and it is technically a plano-convex lenticule, so that's how, and the transition zone, what it has is it burns lesser tissue, and it is a one-piece PI, and it's a curved interface, so again it helps a lot when you're docking with this patient, and it makes it user friendly on how to use this machine. So you can take anything, Schwind Cirrus or MS39. If you have a good SCC control for this patient and the quality of scans are good, you just export it to the Smart Sight machine, and here you get all the details for the right and left eye. Once you import the diagnosis, you get the keratometry, the pachymetry, with the pupil centration, you also get the pupil data of the diameter, the offset, and you can have your automated flap and lenticule parameters, what dimensions you would like to choose. You only have to just enter the refraction here for the lenticule patients of what you would like to correct. At this point of time, you don't need any nomograms, but if you are correcting anything above 6 diopters, you can probably add 0.5 diopters. It's a very easy procedure. You can see here all values are in yellow, and once the laser starts, yes, it does look descented, but it's not descented, it's just the 45 degrees angle camera what you see. It creates a posterior and the anterior plane, no side cut, and then the edge cut, and then you just once it's there, you just go ahead and identify the anterior and posterior plane and dissect it. And because of the asymmetric offset spot spacing, which I'll come to it next, you can do an easy dissection and remove the lenticule. The second advantage here, what we get is, this is a patient was little uncooperative and we had a suction loss after we created the anterior plane. I could have stopped, but I just went on, and after the anterior, the cap cut, it had a suction loss. So what to do next? Should we just abort the procedure, wait for a week or a month for the edema to settle down and do a PRK? No, here we have an option where you can just probably redo the entire procedure again, or you can make only the cap cut or only the incision. So the Schwind has rescue missions where you can choose one of it when you had a suction loss and just proceed with. So here we are just making the incision, and we open the incision and just dissect the lenticule, and the next day patient is 20/20, and there is no residual error, edema, or any such complication. So here you do have rescue missions where you can just make an incision or the cap cut and proceed. So it's much simpler here compared to that of other platforms. It's just a straightforward one thing. And as mentioned here that, because of the Smart Sight Nova, it helps much more precise in the centration of the pupil and tracks the eye movements. It automatically compensates for shifts and it delivers a tailored treatment for every patient, every eye differently. So this is what I was talking about. This is what traditional lasers would be. The spots are just next to each other and you can see the rings are symmetrical. But here with Smart Sight ATOS, the spots can be like, you can customize how much would be the spot and track distance, and that reduces the number of spots you're giving. So now because you are reducing the number of spots, do you have any advantages? Yes, the advantages again here is that the refractive index, the change in refractive index in ATOS is much lesser here compared to that of any other platform, be it Smile Pro or Silk, which means that the healing is even faster compared to others. The interface here is much smoother because of the asymmetric spot spacing compared to that of Silk or Smile. So again, because the interface is smoother, it does help in a quicker healing and a better visual quality on day one. So now this graphs look little complicated, but I'm just going to simplify it. We do look at something like a Bax BCL ratio, and in the CLEX procedure, which is the ATOS, it was much lesser compared to that of the traditional CLEX procedures, and that's why in Silk it was the spot spacing which helps the quality of vision, but here it's the energies which helps recover in the quality of vision much faster compared to that of other procedures. And because it's much lesser energy delivered on the cornea, always 19% of the cases you do see Bowman's distortion on day one, and that can impact the quality of vision. But here, because the energy delivered is much lesser, there's minimal Bowman's distortion present in the ATOS cases compared to that of any other procedures. And again, because of no side cut, the nerve regeneration here is also as comparable as to that of Silk. So to summarize, yes, this is a low cumulative energy laser which has predictable outcomes post refractive surgeries, and because it's an asymmetric spot spacing, this has a different mechanism, but again the recovery and the quality of vision is much better and smoother here compared to that of other procedures. Thank you.
Thank you. Any questions from the audience?
When it comes to astigmatism specifically, so each of these lenticular extraction, which of them has what cutoff is what I would like, and the quality of vision post-op?
No, no. I think
If
once you get
it's up to 2 diopters and more astigmatism, is
No.
it femtolasic or any of these lenticular extractions?
no, I would even up to 4 cylinders I could easily do with Smile.
Okay.
There should not be a problem. You get to understand your machine and parameters. Maybe some machines you have to change your nomograms. For me, with Vistumax 800, there's absolutely no challenge. I'm able to do it. There's absolutely no harm. If you feel that you have a mixed astigmatism or a higher cylinder, and you feel that if you're doing a flap, the results are brilliant, that the choice is yours. I think by the end of 6 weeks, whichever thing you do, the patients do well. So
So
you
we
can
have to counsel the patient that immediate post-op you will not have good quality.
no, why won't
whichever-
you have? You will have good quality from day one.
Okay.
Whichever you feel as your choice. Would you want to do a flap for higher cylinders? You want to do a contour or anything else? You are welcome to do it. If you have done n number of high cylinders on a Smile procedure and you're doing well, then you can do that.
Go ahead.
So you take a choice.
Thank you.
And you will do well either ways.
Regarding the spherical aberration, are we inducing any aberrations or only the existing aberrations are preserved?
So traditionally, whenever we do any refractive procedure, we are inducing spherical aberration, but here it's controlled. It does induce, but the induction is much lesser, maybe just 10 to 20% of what we were inducing in the past.
Compared to eczema.
Compared to eczema. And I heard from both the presentations that now even Zemer has a biconvex shaped lenticule, and even Smile is kind of changing profile. So I think this is just a good step forward for all the lenticule platforms on how the spherical aberration will be controlled, which will help the. So it will
quality of-
induce, but maybe just 10 to 20% of what it was in excimer laser.
Any questions from the audience? If not, can we wind up the mementos? Mementos are there. Because may I invite who gave that memento? Dr. Sai. I invite Dr. Sai Kumar to give the memento to Dr. Chitra Ramu. Not for only for external. Dr. Sanjeev. And one more, Dr. Pooja. Dr. Pooja. Please. Dr. Once again, thank you, all the speakers and the audience for conducting a very good Lenticule Lenticule IC, and I hope it was useful to everybody. Thank you so much.